people have started joining. So, and I think we've reached time to start. So I'd just like to welcome everybody to this morning's webinar. I am so excited today that we have Dr. David Watts from Trace Elements here. There are lots and lots of people that claim to be the master of minerals or a mineral expert, but David genuinely is. I started working with David about 20 years ago now, maybe, David, maybe
at least
more. And I realized I had actually begun to learn something from you, David, when I emailed you a question and you stopped.
Oh, sorry, Karen.
That's okay. But when I first started working with you, every time I asked you a question, you responded, look in my book, look in my book, look in my book. And then one day you emailed me an answer and it simply said, look in the mouth. And I remember thinking, why can't he just answer a question? And I looked in the book and I emailed you back and I said, look, David, I've actually read the book and I really can't find the answer. And you messaged me back a really long answer. It was like, I don't know why you're looking in the book. I told you to look in the mouth. And we were talking about elevated iron and how it was probably a dental issue. And I just thought, I have actually cracked it. I have finally asked a question that is not in the book.
Yeah, that's true. I always like to, when practitioners call and or ask a question about the lab result, I like to ask them questions so that they'll, find the answer and understand it, rather than me just giving an answer. They think it through, they know the answer, and it just, that's interesting though.
Yeah, okay. So absolutely welcome. Thank you so much for getting up. Absolutely. Well, I don't know if it was the crack of dawn, if dawn had even broken when you started, because I know it's really early where you are. But thank you so much for joining us. I am going to hand over to you, David, to talk about metabolic typing. So thank you.
Thank you. Thanks everyone for joining us this morning. Really appreciate you being here, and hopefully we can provide information that you can take back to your practice and be able to incorporate it. And some of this will be a review for many of you. And but today we're going to be discussing metabolism, biochemical individuality, and metabolic types as determined from the HTMA patterns. First of all, again, I'd like to thank Karen Watkins at Mineral Check. She's been involved in this type of studies for over 25 years. I've known her for at least that many years. And she has a great deal of practical information and experience in the field. So she's a great asset to all of you in Great Britain. I'm David Watts, president of Trace Elements Incorporated, which is a clinical laboratory in Dallas, Texas. And we were established in 1984, so we're going on our 41st year. And through our subsidiary, International Trace Element Laboratories, we provide services to clients in over 40 countries. So what is metabolic activity? Well, basically, it's a biological process that occurs within all living organisms. There are chemical reactions that are regulated by enzymes. These enzymes are basically activated largely by minerals, and vitamins act as coenzymes, and they work synergistically with minerals. And so without these enzyme activities, then there's going to be a suffering of the cell metabolic activity, and of course energy production via ATP. And these are some quotes I'd just like to bring out because I think they're very pertinent, even though they're quite old, but they're still, I think, as applicable today as they were back then. And this states that perhaps the most important issue in nutrition relates to the interpretation of guidelines that include advice to increase or decrease components or to eat more or less of others. Now, this may be applicable to a population. They may not be appropriate for any one individual. Before a person knows how to modify their dietary intake in either direction, they have to have some idea of where they stand in relationship to those recommendations. About a century ago, the French scientist Gabriel Bertrand established what he called Bertrand's Law. And the law states that for each biological system, there's a range of exposure compatible with and essential for optimum nutrition or optimum function. Below and above that range, function deteriorates, resulting in a disease and ultimately death. One of deficiency, another of toxicity, because both must be considered before any nutritional intervention can be safely implemented. So this is the whole purpose of being able to determine metabolic individuality. You're assessing the individual regardless of the disease state. The role of nutrition today, and this goes back, which was published in the American Journal of Clinical Nutrition in '97, says the concept of health and dietary recommendations have been expanded to include achievement of genetic potential for growth and development, prevention of disease, not just nutritional deficiency disease, but chronic and degenerative diseases, and the extension of longevity. Now, to me, that's an extremely powerful statement. That's what you all are doing, is providing this for your patients. This is an article, again, from UNICEF, where they're talking about a large percentage of the world population, especially in underdeveloped countries, who have nutritional deficiencies. And they say when a child needs iron or vitamin A or iodine, they need it now. And if he or she doesn't get it, then we will be paying for the rest of our life to take care of those. But if you meet those needs, the positive outcomes are absolutely glorious. Now, many years, as you know, the medical profession says, there's no need for any type of nutritional supplementation other than eating a balanced diet. But some years ago, they reversed that policy, and they basically state, due to the fact that research has shown that American diet is sufficient to prevent extreme vitamin deficiency, such as scurvy, beriberi, pellagra, insufficient intake well above those causing deficiency syndrome are risk factors for developing chronic diseases. Now, this is what we can term subclinical nutritional deficiencies. In other words, they often go unnoticed until they manifest in a more serious health issue. For example, iron deficiency, before the onset of iron deficiency anemia, individuals can experience low iron stores in their tissues and without obvious symptoms. But it can lead to fatigue, decreased performance, even in the absence of anemia. Osteoporosis is another example. Bone density can decrease significantly before any changes in the blood or urine calcium levels are detectable. Many times there is no change at all, even though there's severe osteoporotic development. Factors like vitamin D deficiency or inadequate calcium intake can contribute to the condition silently over time. These examples highlight the importance of regular screening and awareness of nutritional health, even when no overt symptoms are present. So early intervention can help prevent more severe health problems later on. Now, there's many factors that affect our nutritional status. And of course, one of the first ones I have here at the top is mineral depletion in the soils. We've known for a long time that this has been occurring due to agribusiness and over farming, and therefore, when there's inability to grow the crops and produce the nutrients in there, our diet is going to suffer. Food preparation techniques can also impact nutritional status or the nutritional availability of our foods. Dietary habits, environmental pollution, heavy metals can all contribute to our nutritional status, as well as factors such as genetics. People are predisposed, and then metabolic disorders, individuals with metabolic disorders, serious illnesses, stress. In other words, life in general, can be contributing to our nutritional imbalances and deficiency. And medications, see, is a large one that I don't think is being addressed at all by the medical profession. They found in the U.S. approximately 25% of the adults over 65 years and older take on the average of 5 prescription drugs. This doesn't include over-the-counter medications that they might be taking. And we know that medications can deplete numerous nutrients in the body. Corticosteroids, anticonvulsants, they can deplete calcium, magnesium, vitamin D, potassium. Diuretics are known to deplete magnesium and potassium, zinc, thiamine. And of course, PPIs, these are proton pump inhibitors that people use for digestive problems. And they're only supposed to be used for a short period of time. But many people are taking these for years, and they have dyspepsia and so forth. And it's not, treating the cause, it's just covering the symptoms. But PPIs are notoriously known to deplete magnesium, which is one of the most important minerals in the body. It activates over 300 enzymes. And so that magnesium, we've seen many people who had PPI intake for years and depleted their magnesium to the point they were having cardiovascular irregularities due to that. And we stopped the PPIs and deal with the digestive issue, and they would respond quite dramatically. And then, of course, metformin, which is commonly used today for glucose control, that can deplete B12. And of course, we all know about statins and the CoQ10 depletion. Minerals are extremely important. They're involved in almost all biochemical processes and interrelated to all other nutrients, including vitamins, minerals, proteins, carbohydrates, and fat. And any imbalance, between these minerals in our body can contribute to an abnormality in these different systems of the body, such as the skeletal system, the neurological system, and muscular activity, even the immune system, and even interfere with DNA activity. This is a chart called Moulter's chart. And so we need to be aware of the antagonism among nutrients, especially the minerals. And this chart is a chart that he developed based upon soil mineral interrelationships, and showing the antagonistic relationships and the synergistic relationships in this chart. And he developed, this was published back in 1953 by Cornelius Mulder, M-U-L-D-E-R. And this publication, was a milestone in the understanding of soil chemistry. It made a huge impact on our ability to have healthy soils, healthy plants. But this antagonism also occurs within the body. Now, this is a biological wheel that I developed. And so the lines in this wheel are showing arrows pointing in both directions, indicating a mutual antagonism among the minerals. And simply the first one here at the top is calcium, and the bottom of the chart is magnesium, with the line drawn and arrows pointing in both directions, indicating that there is an antagonism between those two minerals. So excess of one can deplete another. Now, the same thing applies, this antagonism, to vitamins. And here I have a vitamin antagonistic wheel showing some of these antagonisms. And for example, at the top, we have vitamin A, and then we have a line drawn to vitamin D, indicating a mutual antagonism. A lot of people don't take that into consideration when they're giving vitamin D. They don't know the person's vitamin A status, but vitamin A is well known to reduce the toxicity of vitamin D. And there's an antagonistic relationship also among the vitamins, or between the vitamins and the minerals. And here showing some of those. And at the top of the chart, we have vitamin A, with an arrow pointing toward calcium, and in both directions. And vitamin A is well known to antagonize calcium and cause an increase in the excretion of calcium from the body, and excess calcium in the body then can increase the requirement for vitamin A. So over the years, we put together these antagonistic and synergistic charts, and minerals tend to work in pairs and sometimes triplets. And so here we just categorize some of the nutrients, not all of them, all the minerals, but many of them, into their synergistic relationships. So calcium, phosphorus, magnesium, see, those are all important synergistically for the formation of normal bone structure, dental structures, and so forth. And there's a synergism between vitamins and minerals as well. This chart is showing some of those, like vitamin D is well known to be associated with calcium, magnesium, and it can impact sodium and copper. Vitamin A, is synergistic with zinc. A person can have a severe zinc deficiency, but also suffering at the same time from a vitamin A deficiency, but not due to a lack of vitamin A intake, but due to a zinc deficiency, where that is necessary. Adequate zinc is necessary to mobilize vitamin A from the liver. There's another statement I really love by Davis, and this is back in even further in 1976. He states that we've just scratched the surface in our research into the relationship of trace elements to the maintenance of human health and disease prevention. Trace elements may be as important in the maintenance of human health or development of human diseases in our present day environment as pathogenic organisms were for a previous generation. So basically, this leads us to a new era in nutrition. Nutrition no longer deals with fully reversible single deficiencies, but with imbalances, faulty regulation of metabolic events, which may or may not have a dietary etiology. And Condra states, rarely does a single nutrient deficiency exist in a person, but nutritional imbalances are common. And I think we're seeing that today. An average practitioner won't see a person with scurvy or beriberi unless they're working in some of these undeveloped countries. But what we see in our everyday practice is nutritional imbalances, which are impacting a person's health. And he states that mild and subclinical deficiencies of nutrients outnumber overt symptoms by 10 to 1. So what is biochemical individuality? It highlights how each person's unique genetic makeup, lifestyle, environmental factors, I think they call it now the episome, and how those influence their health. Nutritional status is not solely determined by what one eats, but also about how effectively the body retains and utilizes these nutrients. Factors such as metabolism, gut health, stress levels, and illnesses can impact nutritional absorption and utilization. As a result, understanding an individual's specific needs is crucial for optimizing health and nutrition. So we want to be able to personalize and target these individual requirements. Now, one of the first authors talking about biochemical individuality is Dr. Roger Williams from the University of Texas. He did extensive research on analyzing the blood chemistries of patients, many of them in the same environment, many of them in the same family, and he found markedly different chemistries on those people and the several-fold differences in the nutritional requirement for these individuals. Again, even though they were in the same environment and eating even the same diet. He also discovered pantothenic acid and written over 20 books. And another gentleman, Dr. Melvin Page of the Page Foundation, he was determining metabolic types by using various measurements of the body, anthropometric measurements of the upper and lower extremities in conjunction with blood parameters and other physical characteristics. Dr. Page noted his findings correlated with certain neurological and endocrine characteristics, which he categorized as sympathetic or parasympathetic dominant. Now, Dr. Page used small amounts of hormones, and he assessed changes in individuals' blood chemistry which were influenced by these various hormones. And he found that the sympathetic nervous system regulated phosphorus level in the blood, and the parasympathetic regulated calcium within the blood. So we have to bring in the neuroendocrine influence upon how it impacts our nutritional status. And of course, the neuroendocrine system influences nutrients at several levels, including absorption, excretion, transport, and utilization. And trace elements, on the other hand, can exert influence on the neuroendocrine system. So we can influence the neuroendocrine system through nutrition. Dunbar states that the endocrine glands translate the tempo of the nervous system into the tempo of metabolism and vice versa. So again, this is reiterating what I said, that not only does neuroendocrine system affect our nutritional status, but we can affect the neuroendocrine system through nutrition, and of course, through medications, through herbs, and so on. Now, Dr. Watson, who wrote Nutrition in the Mind, the psychochemical response to, the psychochemical response. He recognized individual metabolic types according to what he termed the cellular oxidation rate. Now, oxidation is the process by which adenosine triphosphate, ATP, is formed, and it's the major energy constituent of a cell. It requires normal function of two cycles, basically the glycolytic cycle and the Krebs cycle, for adequate production of energy. Each step of these two energy production cycles require individual nutrients for their completion. A lack of any one or excess of specific factors can contribute to a reduced or accelerated cellular metabolic rate. Therefore, Watson used the terms fast and slow oxidation type. Now, let me go back on here. At the time that Dr. Watson was formulating his premise on oxidation type, he basically was using blood parameters to determine this, as well as questionnaires. And so he would do the carbonic acid, CO2, plasma venous pH, 6-hour glucose tolerance test, and an extensive questionnaire. And when I was in practice and first started looking at metabolic individuality, I mean, I used a lot of those in my practice. I would test these patients for these constituents that he recommended. And a lot of times it would still be somewhat of a guesstimation of where they fell into a fast or slow type, because he didn't have, or he didn't utilize other tests like the HTMA, which provides us much more nutritional information than he was getting just from those parameters he was testing. So the first step of energy production in the body is the glycolytic cycle. Here I'm showing the glycolysis cycle, and it basically has 10 steps, and that it goes through, and each one of these steps require a mineral, a vitamin, protein, and this occurs in the basically the end product is pyruvate, which is produced in glycolysis. And also this is a anaerobic type of metabolism that occurs in the cytoplasm. And then what happens, the end product of the pyruvate, as we can see here, glycolysis occurs in the cytoplasm, and it produces pyruvate, which combines with coenzyme A, to kick off the citric acid cycle, to form the citric acid cycle. And the Krebs cycle occurs in the mitochondria, of the cell, and that produces the most ATP. Glycolysis produces ATP, but not nearly in the quantity that is produced in the mitochondria. And this is an aerobic environment where it requires oxygen to take place, to produce ATP. Now, there's a link between the two. When glycolysis is not functioning adequately, then pyruvate levels drop. So if there's a slow activity or reduced activity due to any type of blockage or something, and pyruvate production is reduced, then there's lack of pyruvate to enter into the Krebs cycle. Conversely, if the Krebs cycle is inhibited, perhaps by, and any of the steps of the Krebs cycle is prohibited, then it's going to cause a backup of pyruvate, so you can get an excessive amount of pyruvic acid building up. And any number of things can inhibit those steps, such as hypoxia or oncogenic mutations like DNA, mitochondrial DNA mutations, and so forth. And this is if this is blocked, then the cell reverts to anaerobic metabolism, and that is a factor that is commonly associated with malignancies. And so malignant cells largely proliferate, grow, tumor growth and so forth occurs because of the cell reverting back to a glycolytic cycle. This is known as the Warburg effect. It's in characteristics of many cancer cells, which preferentially metabolize glucose to lactate instead of oxidizing it in the mitochondria. This shift not only supports the metabolic intermediates for biosynthesis of the tumors, and it will actually contribute to the tumor and or spread of the tumor. And then this is the basis, for the PET scan determining cancer in various parts of the body. They use a radio-tagged glucose and injected it into the body. And then the PET scan will pick up those areas where there's high glycolytic activity, indicating a strong potential for a malignancy. Basically, the neuroendocrine system is balanced in a way that it fluctuates like a rheostatic balance. So we have the two branches of the autonomic nervous system, and of course we categorize the endocrines into the sympathetic, parasympathetic categories as well. But typically there's a rheostatic balance where the sympathetic can be engaged when there's stress, when there's fight or flight condition occurring, and then the parasympathetics will come into play to combat that over sympathetic activity and bring things back to somewhat of a normal balance. However, sometimes the neuroendocrine system can become imbalanced and stay that way for a period of time. For example, extreme stress and so forth can increase the sympathetic activity, and it will actually be suppressing the parasympathetic activity. And so this also is common with humoral autoimmune conditions. So this basically can lead to sympathetic autoimmune conditions or responses. And the opposite, the sympathetics can be overcome or suppressed by excessive parasympathetic activity and overreaction. And this contributes to the increased activity of the cellular immune response. And so we can have a parasympathetic autoimmune response. When we discuss these conditions, like autoimmune response, we just generally speak of those generally. And but we need to determine which side of the immune system that needs to be addressed, right? You can't just support a person's immune system in general, to get a response unless you know which side is going to be dominant. So the endocrines have an antagonistic relationship too, just like the vitamins and minerals and vitamin-mineral relationship. So here I have a chart showing some of these endocrine antagonisms. And at the top here we see estrogen, and we see a line with arrows pointing toward progesterone in both directions, indicating there's an antagonism, between estrogen can suppress progesterone and vice versa. We also see estrogen can have an antagonistic effect on the thyroid, and then high thyroid activity can actually have an adverse effect on estrogen status. And then, of course, the thyroid, parathyroid are mutually antagonistic as well. So to try to make sense of all this, what we've done is to categorize the endocrines, neuroendocrine system into, the sympathetic, parasympathetic category. Here I have the parasympathetic endocrines listed, and they start with the lateral hypothalamus and continues into the posterior pituitary, the adrenal cortex, the endocrine pancreas, insulin, the parathyroid, and the ovaries. And so minerals have an impact on, as again, we said previously, on the absorption, retention, utilization of minerals. And so here's just a couple of examples. If a person has a high estrogen level, then that's going to lead to an increased retention of calcium and copper, and an increased loss of phosphorus, magnesium, chromium, zinc, sodium, potassium, iron, manganese, for example. And so these endocrines also affect the mineral relationships or ratios. And so here, when we see an estrogen dominance, we can see that there's going to be a ratio differential between calcium and phosphorus, calcium and magnesium, potassium, sodium, and iron. And it's not just those, and also a decrease in the ratios between zinc, copper, and iron and copper. And it's just not those minerals that are being affected. As we said before, minerals or enzyme activators, vitamins are coenzyme. Vitamins work with minerals. So it's not just those minerals being affected, it's those cofactors are being affected as well. So how do we determine metabolic types using HTMA studies? Well, basically, Dr. Page found that the ideal ratio between calcium and phosphorus in the blood was about 2.5 to 1. When he used the hormones, he found that the parasympathetics controlled calcium, and phosphorus was controlled by the sympathetic neuroendocrine system. And I find that calcium to phosphorus in the ratio in the hair is very stable, and that's why I use the calcium to phosphorus as the indicator for sympathetic and parasympathetic dominance. And so here we see on our significant ratio chart an elevated calcium to potassium. So that indicates a slow metabolic pattern or a parasympathetic dominance. And this is typically a parasympathetic mineral pattern. I mean, you all who have used HTMA, I think you understand this. I don't have to explain the graph to you very much, but basically here we see the sedative minerals, calcium and magnesium being elevated relative to phosphorus, iron, sodium, and potassium. And so this would indicate, there's a reduced glycolytic activity, or slow metabolic rate, and there's a reduction in normal pyruvate production. And also, when we evaluate the rest of that pattern, we see that the endocrines that are dominant there include the thymus. The thymus is typically dominant in these slow parasympathetic patterns. And this is why they have a propensity for developing cellular autoimmune conditions. And insulin is dominant when we see an elevated calcium to magnesium ratio, and estrogen is going to be dominant many times when we see a low zinc copper ratio. And so the therapy, is simply reduce those factors that would further slow the metabolic rate and enhance those dietary factors that would help to speed up the metabolic rate. Now, this leads also, as Dr. Page published in his book, physical characteristics, which include low blood pressure, cold extremities, peripheral fat distribution, and type B personality characteristic. And so he showed the difference between a normal silhouette of a person here and then a parasympathetic dominant pattern. And you can see here that there's excessive peripheral fat distribution of the hips and thighs here. And like I say, his studies, we're using not only the blood chemistries and hormones to impact those chemistries, but he used anthropometric measurements, of the upper body and lower extremities to determine this body type. So when phosphorus is dominant relative to calcium, then that would indicate a sympathetic dominant pattern. So here we can see a low calcium to phosphorus ratio at 1.3, and leading to a sympathetic dominance. So here's a sympathetic mineral pattern, and as you can see, the calcium and magnesium sedative minerals are low relative to phosphorus, iron, in this case, sodium and potassium. And this would indicate a increase in glycolytic activity, therefore leading to a fast metabolic rate and an increase in pyruvic acid production. And also physically, we see these individuals having a warm body temperature, elevated blood pressure, perspire easily. They have the central adipose deposition or apple-shaped body structure. And typically they have a type A personality trait. So this is the drawing that Page depicts in his book, showing the two different body characteristics. Again, this was the parasympathetic pattern, or individual with the peripheral fat distribution. And here we have the sympathetic pattern, and that's more with the central obesity occurring here. Okay, and this is common in many of your cases with metabolic syndrome. Okay, and that's the metabolic syndrome. Describes this quartet, a deadly quartet they call it, where there's upper body obesity, glucose intolerance, hypertriglycerides, and hypertension, and that's what you see commonly in your sympathetic dominant individual. Now, not always, obviously, it's not always 100%. There's always variations. You can be very thin and have a sympathetic dominant pattern. You can have a fast metabolic pattern, sympathetic, and be extremely obese. And same way with a slow metabolic type, because you can have obese, slow metabolic types. You can have very thin parasympathetic types, but they're different. You have to treat based upon what you find their metabolic characteristics are, and not based on their health condition or their symptomatology. We've done numerous, like I say, we do tests in over 40 something countries, and over the years, I did the studies looking at the percentage of sympathetic and parasympathetic dominant individuals in different countries. And here we have the United States on the left side, and we have approximately 75 to 25% difference here. 75% of the population show a slow metabolic rate, and about 25% fall into that sympathetic metabolic rate. Now, I haven't done this recently, probably in the last 20 years, so it may change. I should update this to something more current, but you can just see that most of the countries fall within a similar ratio. And England, of course, is about 85% parasympathetic and 15% sympathetic. And what's interesting, this country here, Norway, it's almost equal. It's almost 50-50. It's 45-55. And that's quite a remarkable relationship there compared to all the other countries that we've analyzed this way. And I've asked what the explanation is, and that they have a number of things in their society there that could be a factor. Acid rain, acidic water, but they're Vikings, so they're pretty tough people and aggressive people. So maybe that's part of the reason their inherited genetic characteristics, leads to the offspring of faster metabolic types. Now, the reason it's important to determine metabolic type is because each type has susceptibility to certain health conditions. In other words, it occurs more in one metabolic type than another. And this has been based on correlating HTMA patterns with patient history, symptomatology, and other clinical tests, and even psychological evaluations. So again, when we see the different metabolic types, you'll know that they'll be susceptible to certain health conditions, just in general, without having a test on them at all. Any type of test on them, you can tell by their body structure, their body temperature, and so forth. And so let's just look at anxiety. Anxiety is common, more common in a sympathetic individual compared to depression in a parasympathetic individual. Now you may say, why? Why is that different? Well, anxiety is brought about by a number of things, but not the least of which associated with magnesium deficiency and calcium deficiency, but also lactic acid. And so in the glycolytic cycle, the sympathetic types have a high rate of lactic acid pyruvate production, which is converted into lactic acid. And that causes anxiety in itself. And then depression is more common in the parasympathetic group, because why? Largely that's related to a severe energy loss, fatigue and so forth. And we see now this, anxiety can be in both groups or either group, as well as depression. Like in sympathetic type, you do see manic depressive disorders. These are people going from extreme highs to extreme lows. And but depression is more of a low, continuously. But they can develop some anxiety too. But I think that's more like agitated depression. But we're talking about clinical depression here in those cases. Rheumatoid arthritis, for example, is common in your sympathetic group, and osteoarthritis is more common in your parasympathetic group. Here's a few others that we've categorized, and we could recognize two different forms of MS in multiple sclerosis type 1, in the sympathetic group, and then multiple sclerosis type 2 in the parasympathetic group. Parkinson's is common in your sympathetic, as well as a lot of other neurological conditions such as ALS and so forth. And then your autoimmune conditions are very more common in your slow metabolic types, such as lupus and scleroderma. So let's just look at the subtypes. We have the two major metabolic types, the sympathetic and the parasympathetic dominance. And so here is a typical parasympathetic pattern. And so the subtypes are basically a desynchronization of between the nervous system and the endocrine system. So we have the type 1, slow type 1. Here is a slow metabolic type 2. And as we can see, the sodium is elevated considerably here relative to magnesium and potassium in this case. So that's indicating that this is an alarm phase stress reaction occurring. And it could be psychological. We see patterns like this who were victims of individuals who were victims of stalking, and so forth. And so it could be an alarm phase stress reaction, which is temporary. Hopefully the body will respond and overcome that stress reaction, which would produce a pattern, which would produce a recovery. But this is a pattern for the slow type 3 is where the potassium is elevated relative to calcium and relative to sodium. And that is a pattern where the anti-stress hormones are kicking in, and it's trying to suppress that pro-inflammatory reaction. And eventually that would even out, but it can stay chronic. And then obviously when there's a sodium potassium disturbance, it could be related to renal conditions, or could be related to steroid intake, any number of things. And then of course the slow type 4, basically has the sympathetic, parasympathetic nervous system activity, but they have sympathetic endocrine activity showing, that the adrenals are elevated relative to potassium. And this could be, basically going into a recovery stage of the stress episode. And the sympathetics, the sympathetic or fast metabolic type 1, has the elevation of the stimulatory minerals relative to calcium and magnesium. And the type 2, again, is related to this sodium elevation relative to potassium, but also an elevated calcium relative to potassium. I said that wrong. Sodium to magnesium, and then the elevated calcium to potassium. And again, that can be an alarm phase, stress occurring, renal dysfunction, and then the type type 3 is where there's a low sodium to potassium and an elevated sodium or low calcium to potassium. Again, indicating a possible glucocorticoid dominance. And the fast type 4, this is basically your pattern of a sort of a stress burnout. You know, this person may have been a sympathetic type majority of their life under high stress conditions and so forth, and they will eventually sort of, you know, we use that term burnout, and they're starting to go into a parasympathetic pattern, and they will eventually, the calcium and magnesium can continue to rise relative to sodium and potassium, and so that'd be related to an adrenal insufficiency. So let's just look at some practical applications here and how we can develop a precise nutritional approach based upon biochemical individuality using the HTMA. So this, this was a patient diagnosed with osteoporosis, and we classified them as an osteoporotic condition type 2. And so basically here, looking at this slow metabolic pattern, the first thing that we can use the HTMA for is to determine what a person doesn't need to be doing, you know, what is contraindicated for them. And then obviously we can know what is indicated for them. But here, let's look at this pattern and look at the contraindications for this patient. Well, first of all, you know, we can see the high calcium and magnesium relative to phosphorus, sodium, and potassium. So this is a very sedated pattern. And so calcium would be contraindicated in this patient here, right? Calcium supplementation, as well as its cofactor, vitamin D, they would both be contraindicated, you know, because of this relationship, the calcium being high to phosphorus, calcium being high to magnesium. Now, you will find many patients with this pattern will actually have low vitamin D level in the blood, right? And but that's not causative. That's a result of the pattern. Okay. In other words, you can't correct that by giving more vitamin D, you know, because you can get it up there using pharmacological dosages to a higher level in the blood, but it won't maintain itself, and it won't necessarily stay there once you discontinue it. And so the reason that the vitamin D is low is a compensatory mechanism where, you know, as the tissue calcium levels build up, then, you know, it's being resorbed from the bone, it's being absorbed by the kidneys, it's being absorbed from the intestinal tract. And as all this calcium sources enter the blood, it has to go somewhere. If it's not being excreted, then it's going to go into soft tissue. And the more calcium in soft tissue, that reduces the ability, or that reduces the conversion of stored vitamin D to the active form. You know, so once you reestablish that mineral balance, vitamin D levels will improve. And then cobalt would be contraindicated, as well as copper. In this case, we can see an elevated copper or low zinc copper ratio. Boron would be contraindicated, B12, CoQ10, estrogen, soy, sedative herbs, and then hard water. So indications would be to increase the phosphorus intake, zinc, magnesium, vitamin A, C, E, B3, B1, B6, and you could get progesterone in this case, you know, if it's a female, because of if there is that low zinc copper ratio, that would indicate a estrogen to progesterone imbalance. But in a male, which we've seen quite often and through other testing, you know, this is related to low testosterone levels as well, and can impact, you know, sperm production and motility of the sperm. And then, of course, this patient could use some thyroid and adrenal support. And let's just look for a moment at the thyroid antagonisms. And so here we see a number of factors that can contribute to reduction in normal thyroid expression. And so, as we mentioned earlier, estrogen can suppress the thyroid, insulin can suppress the thyroid, parathyroid hormone can suppress the thyroid, and some of the minerals and vitamins, such as lithium, calcium, can all suppress the thyroid activity. So what we've done is to classify nutrients then into stimulatory sedative categories. This is not complete by any means, but just to give you an idea of how we review this, the stimulatory minerals include phosphorus, sodium, potassium, iron, manganese, and so forth. And sedative includes calcium, magnesium, zinc, and so forth. There are transitional minerals. They can do both. They can stimulate and or sedate. So, common sense tells us then that, if you have a person that's a sedative or a parasympathetic dominant, you would reduce those factors that would further lower the metabolic rate. If you had a person that's overstimulated, you would reduce those stimulatory nutrients in the body. So this is what we would call osteoporosis type 1, which is related to the sympathetic neuroendocrine dominance. And so let's look at the indications and contraindications for that type of pattern. So obviously, the first thing that would be contraindicated in a pattern like this, well, it could be any number of things, but in this case, I've got vitamin A listed. Now, vitamin A, as we know, does antagonize calcium retention, and obviously vitamin A also enhances thyroid expression. And so this patient, and it raises potassium. So vitamin A is already, potassium is already elevated relative to calcium. So vitamin A would be contraindicated. High amounts of vitamin C and B3 and zinc and iron, that would be contraindicated due to that low copper and high zinc copper ratio. And testosterone then, due to that zinc copper imbalance, indicating elevated or dominant testosterone would be contraindicated, as well as thyroid. And then foods containing phytates, oxalates, fructose. High histamine foods will be an irritant. These people can be highly sensitive to high histamine foods. And of course, indications would include copper, calcium, vitamin D, magnesium, B2, CoQ10, B12, estrogen, and thymus support. So again, you just look at those stimulatory sedative nutrients that give you an idea what to give and what not to give, or what to recommend and not recommend. So let's put this in a practical manner here, a practical situation. Let's say you have that patient, like this. He's suffering, coming to you, he's having, high blood pressure, anxiety, nervousness, cramps, cardiovascular irregularities, and you're treating them, and with therapy, and he's not responding. You go, well, what am I missing? You tend to blame yourself for that, right? I always do. But then you gotta be a detective and try to find out more. Why is he not responding? Because they should be responding. And so let's say if this gentleman came to you and he drank 2 pots of coffee a day, or he went to Starbucks, 4 times a day with these half-gallon cups of strong coffee. Well, this is a mineral analysis I did on coffee some years ago, and I just put this on a patient graph just to give you a sense of how we look at this from the standpoint of what we consider stimulatory and sedative. So here, we can see this coffee, contains a huge amount of potassium, over 3,000 milligrams percent. And that's pretty high relative to calcium. And then, of course, it's very high in phosphorus relative to calcium. So it's very stimulatory, right? And not only because of the caffeine content in it, but also the fact that those minerals are present. And you talk about, if any of us have had too much coffee and you get the jitters, you get the shakes, right? Well, it's largely that potassium that's doing that many times. And but it's also an acidic beverage, and so the sympathetic type is considered more acidic, cellular acidity, and they should be taken off any further foods that could cause further cellular acidity. Now, let's say he drinks half a dozen Coca-Colas a day. This is a mineral pattern and Coca-Cola. And basically, we can see it's stimulatory. It has a phosphoric acid there. So it's low calcium and magnesium relative to phosphorus. And then, of course, it has high sodium. And then, of course, there is caffeine in sodas, and there is it has an acidic pH, further contributing to that patient's perhaps clinical condition. And so, the patient's not responding, and you're doing your best to help them, and you got to go, why aren't they responding? So you just got to delve into their their habits, their dietary habits, and even their social habits too. So let's say he makes that coffee with soft water, and here's a mineral pattern that I put together on soft water. We analyze soft water, and it's not terribly high in sodium or potassium, but see, it's extremely high relative to calcium and magnesium. And so soft water, is considered stimulatory, and it has an acidity to it, whereas hard water, has elevated calcium and magnesium levels, sedative minerals in it, and it is more alkaline. So it has more of a sedative effect. So switching this gentleman from, the high soft water intake to hard water intake would be beneficial for him. Now, a lot of times, over the years, I always try to categorize herbs, so forth, into stimulatory sedative categories. And so I've done a number of analysis on herbs, and this one is is kelp. And so when we look at this, we can see some pretty high levels of certain elements, but the one thing I wanted to point out to you is the arsenic is high, is elevated here, and even cadmium. Now, we can't say that all kelp products have those metals in there, but it all depends on where it's obtained and so forth. Same way with any type of food product. Some can have extreme amount of heavy metals, and others may not, depending on the soil and so forth that is grown on. Now, this is a analysis of peppermint leaves, and years ago that was so highly recommended, for people with stomach and digestive issues. And I think we can see why it was somewhat helpful, because of the aluminum content. The aluminum is sky high in there. And so, that is a source. A lot of people say, where am I getting these minerals from? And a lot of times we can't determine where it is exactly. And it could be something that they're taking that you don't know about. Their neighbor may be suggesting this or that. And so these sources can be from anywhere. And this is a comfrey, and we can see again the high level of aluminum in comfrey. And then, high iron levels and so forth. So basically, in conclusion, just want to say that hair mineral analysis is recognized as a nutritional and heavy metal screening tool. However, it extends far beyond that, and it's been long recognized that HTMA can be a reflection of metabolic activity. Nutritional imbalances can obviously contribute to adverse health conditions, but it should be noted that most adverse health conditions have underlying metabolic disturbances involving the neuroendocrine system that conversely contributes to nutritional imbalances. This recognition of HTMA as an overall metabolic indicator is not well understood and often underappreciated, yet there's considerable amount of research data out there that helps to support what we have found through the HTMA studies over these many years. Well, that's my conclusion. 59 minutes, 16 seconds. So we did it on time. And I want to thank you all for your attention. And where do we go from here, Karen?
I'm just answering questions over on the chat, so I have some to ask you in a moment. But I have to say, I found that coffee slide both interesting, and it did sort of make me wince slightly, because I've recently started drinking coffee again. And when you put that slide up, I was like, now I know why. Which probably tells everybody who's listening quite more about my chart personally than they needed to know. But that was absolutely brilliant. And I am going to borrow from you the peppermint and kelp slide, because they were really interesting too.
Yes, fine, fine.
Okay, so I have some questions that have come up in the chat, which were just, I thought, quite interesting, and I'll put them through. And if anybody wants to put questions in the chat, I'll pick them up and check that we get them covered. So the first question was, is there evidence to show that adjusting the mineral patterns will change the body shape?
Yes, Dr. Page was able to show that, okay, but it can change it, but it won't necessarily shift it, you know, from a sympathetic pattern, peripheral fat distribution to a sympathetic. And so, no, I can't say that it would change it. It certainly would change it, but if we're going to change it back to a normal pattern or a sympathetic pattern, no. Not that I've seen.
That's the thing I find when working with people. And what I explain a lot, you either are fast metabolizer or you're a slow metabolizer. Neither one is better than the other. I think it's really about balance within that type.
Oh yes, absolutely. Because you know, people, you know, these characteristics, you know, occur in different professions and so forth. There's professions that you know, thrive under a sympathetic pattern, and others that thrive under a parasympathetic pattern. You know, like the Navy SEALs. You know, for example, they're pretty much sympathetic dominant people, I think, largely. And you know, compared to accountants, you know, they may be more on the slow metabolic pattern side.
Exactly. I do remember a long time ago you telling me that when you were asked to input on decorating at home, you changed your copper zinc balance to be more helpful.
Mm-hmm.
Now that always made me smile. That one stuck in my mind. Can menopause shift someone from a parasympathetic to a sympathetic?
Yes.
Yeah. Yeah.
Yeah. In other words, obviously, you know, that's an estrogen depletion. You know, if the adrenals aren't taking over adequately to produce it and so forth, and yeah, they can shift. In other words, what we find, you know, when we do ages, you know, when we basically look at the metabolic characteristics from 0 or one day old to 100, but most everyone is born as a sympathetic dominant, right? And you know, I would say 90%. And then in time, they can shift. They'll shift into that slow metabolic pattern, and then eventually, as they get older, they start shifting into a sympathetic pattern. And this is why women, you know, have a high predisposition to cardiovascular disease, which equals men after a certain age, right? In other words, they don't have susceptibility to heart disease like men do, you know, because men tend to be more sympathetic dominant, women more parasympathetic dominant. But after that shift, then they become sympathetic, and their heart disease rates risk go up to very, very similar to the male population.
Yeah. So let's have a look. Can you change oxidative type from fast to slow or slow to fast just by changing dietary mineral intake?
Yes, you can. Yes.
Oh, that's interesting. So just by changing the diet, you can change the type?
Well, I thought you said diet and minerals. Oh.
Well, I see, for me, I would have said, if you change the diet, you will improve the health outcome, but you might not change the metabolic type.
Well, that's true. Well, that's true. Yeah, you're right. Yeah, you're right.
I think you need heroic help with actual mineral supplementation to start changing it.
Right.
Yeah. Let's have a look. Do you find that chronic disease slows the metabolic rate?
Oh, you have different, you know, you have chronic disease occurring in the sympathetic and parasympathetic dominant pattern, right? And so the sympathetic pattern, you know, that's related to a lot of stress hormones being produced, which are highly catabolic, and that causes chronic degenerative changes, you know, your rheumatoid arthritic conditions and that type of thing. Whereas you have degenerative conditions in the parasympathetic dominant as well, you know, like, you know, osteoarthritis and diabetes and so forth. See, when we look at adult onset diabetes, you know, for example, we see that occurs 80% of the time in the parasympathetic dominant due to hyperinsulinism, right? Now you do have diabetes in the sympathetic type too, but totally different reason. That's related to more of an insulin antagonism and a lack of insulin production, due to low calcium levels and relative to phosphorus and sodium and potassium. And then, of course, they have high glucocorticoids, which raises blood sugar, increases gluconeogenesis and so forth in the liver. You have to treat the individual. But I wrote an article. It's on our website, tracehelmets.com. I think it was called this 6 diabetes, indicators about diabetes. Maybe more than that. I can't remember now. But we can see many different factors contributing to a diabetic condition. Not just the type 1. I'm talking about the type 2. Type 1 obviously is a severe inability to produce insulin due to cell destruction, autoimmune condition, humoral autoimmune response, or destruction or surgery or whatever. And
Oh, okay. I've got a couple of questions that I think are quite related. So I'm going to start with one about strong antihistamines affecting mineral balance. How do strong antihistamines affect mineral balance? And the reason I put this one in is because a couple of questions came in about copper, and I know that the two are related.
Yeah. Well, see, if you look at the people which have more preponderance for high histamines, that's going to be your sympathetic dominant people, right? And so that's, again, copper would be helpful into reducing those histamine levels, and calcium, of course, would be helpful in magnesium to helping to reduce those histamine levels. But the slow metabolic pattern, they're more susceptible to environmental allergens, and so forth, compared to the sympathetic type.
And where you find, actually, do you find that taking antihistamines lowers copper levels?
Don't know. I don't know. I haven't tracked that medication to be able to tell you.
That was actually a personal interest, because I have on a couple of clients, and I found that it seems to, but I'm never really sure. So I was just chucking that one in, really. I'm never really sure if that's that, well, I looked for it, so I found it. But does that really equal a cause, or was that just a correlation in a couple of charts? So I thought I'd pop that one in.
Well, I can tell you this, I guess we could say this, antihistamines does nothing to replete minerals by any means, right?
Yeah, that's a very good point.
So a lot of times you're right. When you're looking at data, you see a pattern time and time again with something, and, that may be on a medication or whatever, but the medication is really just controlling their symptom and not necessarily impacting, their pattern at all. So I don't really know, haven't tracked that to be able to give you an answer.
And one question that was asked was about a single exceptionally high reading, like a high reading for copper. Would that indicate an actual deficiency?
Typically not. You have to take that circumstance individually and look at the overall pattern. You can't look at one mineral and make a huge assessment that it means this or that. Just like, see, a lot of people, they relate copper to estrogen, which is true. But see, estrogen influences copper, right? And zinc is necessary for progesterone production, right? Okay, so copper doesn't increase estrogen, but estrogen increases copper. Okay, so many people will say, oh, you've got this high copper, low zinc, you've got high estrogen. Not necessarily. Other things raise copper, not just estrogen. I mean, you got, viruses, is one of the most common. Gallbladder conditions where you can't excrete copper, it's where it's stored and excreted through the bile. So, it could be, so you can't always relate that to estrogen.
Okay. this is a whole debate that I know we won't really cover, but I have been asked about washing the hair, and I think the question came in about ARL not washing the hair, and I really just wanted to emphasize that trace elements don't wash the hair. Do you just want to back me up on that one, that trace elements don't wash the hair prior to testing?
Yeah, that's exactly correct. We don't wash the sample, and see, some laboratories do. You know, they wash the sample, and it basically strips some of the electrolytes out. Okay, and but they're not wrong in doing it, because their reference intervals are based upon that procedure, right? And so, but you do a test through another lab that washes the sample. I mean, the sodium and potassium, for example, could be 90% lower, in a wash sample compared to an unwashed sample, because based on all the washing techniques that we have, and we've done a lot of studies on different techniques, as well as other researchers that published studies, and you can't determine how much endogenous sources you're taking out, with those extreme washing procedures. So and we rely heavily, on those electrolytes, because, we think they mean something, whereas some laboratories don't put any emphasis on it at all.
Yeah, I explain to people a lot about the importance of sodium and potassium, and why it's really vital we have an accurate reading for those. So thank you for confirming that. I think I've pulled out the main questions. I had just to confirm for absolutely everybody, we have recorded it. If you had signal that was floating in and out, don't worry. We will be sending the recording to everybody. So if you registered, you get the recording, and that should happen probably, where are we? Thursday? Is today Thursday? No, it's Friday, isn't it? So it probably happened on Monday. So thank you so much, David, for coming. I've really enjoyed today. I hope everybody else has. I found it fascinating, and there are a couple of things I want to go back and re-listen to. So I'm sure lots of other people did too. So thank you so much for sharing. Thank you for doing this, Karen. It's great seeing you, and all the best to all the practitioners, and we'll see you again, I'm sure. I think that we will have you in demand, so we'll have you back again, I'm sure. But thanks, David. I really appreciate you coming over, and I really appreciate you getting up so early as well to do it. Enjoy the rest of your day. Thank you. You too. Bye-bye. Bye. Bye-bye.